Good afternoon, everybody. It's great to see a full house. Welcome. I'm Sarah Dash. I'm President and CEO of the Alliance for Health Policy. And for those who are not familiar with us, we are a resource for policymakers, the policymaking community. We're nonpartisan, and we're really here to promote knowledge and understanding of health policy issues. So we're thrilled to have you here. We're here today to talk about surprise billing, which has emerged as a key concern for American voters and the public, and here on Capitol Hill. So I'm not going to belabor it because we have a fantastic lineup of speakers here to explain the nuances of the problem, the issue, and policy considerations that are even being debated as we speak. So before we get started, I just want to make a couple quick housekeeping notes. Please make sure before you leave to fill out your blue evaluation form because we care about outcomes here at the Alliance. And be thinking about the questions you want to ask. You can write them down on your cards. You can stand up at one of the two mics, or you can tweet them to hashtag AllHealthLive. So without further ado, I want to thank Arnold Ventures for their support and for making today's briefing possible. I'm going to invite Mark Miller, who's the Executive Vice President of Healthcare, here to make a couple of welcoming remarks, and then we'll go ahead and introduce our panel. Thanks.
Thanks a lot, Sarah. So just a couple things. First of all, I'd like to thank Sarah and the Alliance. I think these are very good outlets for the work that we sponsor. And just so you know who we are, so Arnold Ventures is a philanthropy. We do research and produce policy. We're trying to support both the Hill, the administration, and the states. We have a lot of different areas we work on: criminal justice, education, which I know nothing about, but also healthcare. And we're very deeply involved in the drug pricing issue right now, and also in the out-of-network issue, which is what this is all about. So if any of that appeals to you and you'd like to talk to us about it, we're happy to talk to you about that, and we can connect you to grantees and people that we're funding in order to get information for you. Today we're going to talk about out-of-network billing, the result of market concentration on the part of particular specialties and the entry of private equity firms. I think this raises costs for all of our commercial our premiums, as well as puts patients, can create a burden for the patient. And I think the thing that's disturbing about this issue is even if you have insurance, you're completely exposed in this situation. You can go into an in-network hospital and get hit with an in-network anesthesiology bill. Just a couple of things I'd like you to keep in mind as you listen to this. I think you'll hear that there's a lot of variability in this practice across hospitals and geography, that there are certain specialties this is concentrated in: emergency room physicians, anesthesiologists, and radiologists, and in the ambulance setting, both ground and air. I'd like you to keep in mind that emergency room physicians and anesthesiologists and radiologists make between $350,000 and $420,000 a year, and in-network are generally paid 200 to 400% above what Medicare pays, and out-of-network get between 450 and 800% of what Medicare pays. I think some of the work that's going on the Hill between HELP and Energy and Commerce is probably headed in the right direction by looking at caps. The caps allow these providers to decide whether they want to be in-network or out-of-network. They can still negotiate, but at least caps the most egregious practices. So with that in mind, I'll turn it back over to Sarah.
Thanks, Mark. Okay, so really pleased today to have a guest moderator for today's panel, Sarah Cliff. Sarah has been doing a tremendous amount of reporting on emergency room bills with Vox Media, which really brought some national attention to this issue. She reviewed more than 2,000 patients' medical records, and I think will start us off sharing a couple of those perspectives. She recently joined the New York Times as an investigative reporter, so I can't think of anybody better to moderate today's session. Welcome, Sarah. And then I'm going to go ahead and introduce the rest of our panel. You'll hear from Jack Hoadley. He's a research professor emeritus at the Georgetown University Health Policy Institute. He retired supposedly in 2017, but he Congratulations. But he continues to conduct research on a part-time basis. In his 35-year health policy career, Jack has completed 6 years as a commissioner of the Medicare Payment Advisory Commission, MedPAC, and held staff positions at HHS, MedPAC, the Physician Payment Review Commission, and the National Health Policy Forum. Next, we'll hear from Frederick Isasi. He's the Executive Director of Families USA. Prior to joining Families, he held positions with the National Governors Association Center for Best Practices, the Advisory Board, and as a Senior Legislative Counsel for Healthcare on both the Finance Committee and the Help Committee. So you can ask him after how that was. Finally, we'll hear from Al Bingham. Al is a senior consulting actuary at Wakley Consulting Group. Prior to joining Wakley in 2016, Al was director of the Office of Special Initiatives and Pricing in the Center for Consumer Information and Insurance Oversight, CSIO, at the Centers for Medicare and Medicaid Services, CMS. I'm trying to win health policy acronym bingo. Has also held positions with Kaiser Permanente, the American Academy of Actuaries, and the Health Practice Council. So I want to ask our panel to join us up on stage. Come on up, speak into your mics. Again, remember to ask, be thinking about your questions. By the way, how many people know of somebody who has ever had a surprise bill? Just raise your hand. Wow. Okay, so just to show how much top of mind this issue is. All right, so I'm going to turn it over to Sarah. Thanks.
Hi, thank you, everybody, so much for being here. Thank you for the Alliance for putting this on what is a pretty important topic that a lot of you here in the room are working on. As Sarah mentioned, my background is reading a lot of surprise medical bills and learning about what those look like. So before we dive into a lot of the numbers and the policy, I was going to just tell you a little bit about 3 cases, 3 patients I spoke with who really spoke to me and gave me a sense of what the surprise billing issue looks like across the United States and what it means on the person-to-person level. The first is a guy named Scott Cohan, and he kind of had the really classic surprise emergency bill, if that is a thing. He is someone who was attacked in downtown Austin, left unconscious, brought by an ambulance to a hospital, and when he woke up in the hospital, the first thing he did, he told me, was he hopped on his phone and tried to figure out if the hospital was in his network, which I think is only something you do here in the United States. He found out it was. He felt relieved, and he went about getting his care. But it turns out he needed emergency jaw surgery, and the jaw surgeon who staffed that emergency room was not in network with any of the insurance companies in the Austin area. He ended up with an $8,000 bill that was only resolved when I called the surgeon to ask about that bill. The other patient who I think about a lot is a woman named Nina Dang. She wrote me an email about her bill where she had been in a bike accident in San Francisco, was taken to Zuckerberg San Francisco General by ambulance, received care. She had broken her arm and eventually needed surgery on it. A few weeks later, she gets a bill for $20,000. It turns out that Zuckerberg San Francisco General was not in network with any health insurance companies, and she did not realize that while she was in an ambulance being brought there. And they've since changed some of those policies and gone in network. California was trying to do some surprise billing regulation based on some of the reporting that I and others have been doing, but it looks like that legislation isn't going to pass this year. The third patient, and probably the patient I think about the most, is a woman named Lindsay Clark. She submitted a bill to this database I was working on for about a year at Vox. And she told me this story about an emergency room visit that didn't happen. She was at home with her young daughter, Lily, who was 2 years old. And if you have had a toddler, 2-year-olds like to put all sorts of things in their mouth. And Lily ended up eating some Dramamine pills that she wasn't supposed to. So Lindsay, her mom, called the poison control hotline and said, what should I do? And they said, well, take her to the emergency room. There's a possibility of overdose. You want a professional to monitor her. And Lindsay's thinking in her head, I don't know if I can afford this because she has an outstanding $1,200 bill from her last emergency room visit, a surprise bill like the type we're talking about today. So what she decides to do is she drives to the emergency room, but she doesn't actually go inside. She puts the Little Mermaid on, the little screen in the minivan, And she thinks, okay, I'm gonna watch my daughter and I'm close enough to run her into the emergency room if something bad happens. But if not, I just can't afford, she told me she was thinking in her mind, I just don't know how much this costs. I don't know what will be a network, what won't be a network. I can't afford to take that gamble. And luckily, Lily was fine. They ended up, after a few hours, after watching The Little Mermaid, they just ended up driving home. But I think it spoke to me, all these stories really paint you a picture where patients are incredibly vulnerable to these type of bills. I think that is the key thing I learned in all the reporting I've been doing on emergency room billing. Patients are really vulnerable, and I think today we're here to talk about some policy solutions that might make patients a little bit less vulnerable. So with that, I will turn things over to our first presentation to Professor Hoadley, who's going to tell us about some of those solutions.
Thank you. Is it working now? Is that better? So I want to talk about some of the numbers. As Sarah told you, we've got the flavor of what happens to people in these situations. And I'm going to try to put a little more data on it, but there are some problems with trying to measure surprise billing. First of all, to use that third story that you told, that's not going to show up in anybody's database because it was a non-event. And so I think you always have to take the numbers with a lot of context as to what's really going on. And of course, there are surprise bills that don't fall into this category. I often talk about the fact we can all get a surprise bill if we didn't realize how expensive a particular procedure might be, or we didn't understand our deductible. Those are surprises. But here we're talking about the specific kinds of surprise bills that occur when you see an out-of-network provider in circumstances that you really can't control. So usually emergency circumstances or other situations where you start out with an in-network hospital, an in-network surgeon, but then somebody else like the anesthesiologist treats you that's out of network. And the data that we have tries to measure the share of visits that have a potential surprise bill. In other words, there is some kind of an out-of-network claim that shows up in the situation. And with this particular analysis by Garman and Chartok, they suggested about 51% of the time with ambulance services, you have the potential for an out-of-network bill. With emergency situations, 20% inpatient, 14% outpatient, regular elective inpatient care, 9%. So even though that last category is a lot smaller, it's still a pretty substantial array of cases. Now again, this is a potential surprise bill if things are settled, if the doctor agrees not to charge, if there's an informal negotiation that occurs. That may not always get picked up in these numbers, but this gives you sort of the frame to work with. Kaiser Family Foundation recently put out a report with a similar kind of analysis on claims with a national rate of 18% for emergency visits. But what you can see here is that this can vary a lot. And what I find striking in this slide is that this includes a lot of the states like California, New York, Texas, New Jersey that have high rates of out-of-network bills where they do have a state law that helps to deal with it. So this may mean the people in those particular states face the potential for an out-of-network bill but are protected from that by state law, or maybe not, depending on the circumstances, and I'll come back to that. But it also includes, the high states on this map include states like Kansas, Tennessee, Ohio, and Oregon that don't have particularly any state law going on. So you've got these different kinds of situations depending on the state. It's also true that rates seem to be somewhat lower in rural areas and higher in urban areas, but there's a lot of texture that we really need to understand about this. This is an interesting one because it talks about the situation in Texas, where at least one of Sarah's examples was from. And it was analysis done of how many times does the hospital participate in a particular insurance network, but the ER docs or some of the other docs in that hospital, practicing in that hospital, are not in network. And the first set of bars there is for the ER physicians. And for 3 different insurance plans, these are situations where the hospital is in network with Blue Cross, Humana, or United, but the percentage of times when there's not a single in-network doctor in their emergency room. And you see that's as high as 63% with one of these plans. And so once you're in the emergency room in that situation, you're guaranteed to have an out-of-network bill, again, whether it might be resolved informally or not. Mark alluded to some of the financial impacts here, and this, I think, really illustrates that further. So on average, on the right-hand bar, physicians in commercial insurance get paid about 128% of Medicare. Again, we know that Medicare is lower, that commercial insurance tends to be a bit higher, but look at the three specialties that are the most common for out-of-network billing: radiology, emergency physicians, and anesthesiologists. The average contracted rate, the in-network rate for these physicians, is successively 200% of Medicare, 300 and 344% of Medicare. So this is the ripple effect. This is the effect of the fact that these physicians can get patients without being part of networks, and so they have the freedom to have higher rates, which in turn affects our overall health costs and in turn affects healthcare premiums. So what are the elements of protecting consumers? And we're going to hear more of that as we go through this panel and in the discussion. But I think it's important to sort of highlight what are the main things. The very first thing that normally everybody agrees on is to protect the consumer by treating the situation as if it was in-network, to limit the consumer to paying no more than normal cost sharing, and to prohibit providers from sending them a balanced bill for whatever amount they prefer to charge over and above what the insurance company pays. So that's the core of protecting the consumer. Furthermore, it's suggesting that that should occur in both emergency settings and those in-network settings in the in-network hospital where you've got you've arranged for your in-network physician, your surgeon, but somebody else like the anesthesiologist turns out to be on a network. So laws need to deal with both of those situations. They also need to deal with all types of insurance. And then to make sure that there's no real spillover to the patient, there needs to be a mechanism in laws to make sure there's a way to determine how the physician will be paid. In a lot of ways, the simplest and cleanest way to do that is to set a payment standard, as a payment standard that's viewed as adequate. You can do that based on Medicare, and in some ways that's the most external standard. You can do a percentage of Medicare. Others, like the Health Bill and the Energy and Commerce Bill, use a rate based on what the insurer normally pays in network. So again, another potential standard. Some states have looked at a charge-based system. That can be more problematic because it can be more inflationary, and the charges that physicians use are well above what insurance typically pays. Another thing that we've seen in states is a dispute resolution process, one that says, both the provider and the insurer get to suggest what they want to pay and then let the arbitrator pick an amount, one amount or the other. Normally it's what's called final offer arbitration, where again, the arbitrator picks one or the other amount, doesn't split the difference. And one of the reasons this can be popular is that it allows both sides to kind of have their say, but it is a more administratively complex and a costlier process than just setting a rate. States that have used this have found that it does encourage informal negotiations, and so that's one of the ways to think of it. We can get more back to the pros and cons of these in Q&A. And as a political compromise, there's also the potential to combine these methods, to set a rate standard, to use something like a Medicare rate as the initial standard, but for certain cases, allow people to go to arbitration. Maybe the circumstances of that particular case were more complex or required a different kind of specialty, and then you could have a more limited set of cases go to arbitration. Often states that have done this have suggested some kind of a more informal negotiation before you get to formal arbitration, again, as a way to try to settle most cases without going to the extra administrative process of arbitration. And then finally, another alternative is to go with a method that would require hospital charges all to be bundled together, both the physicians you see in the hospital and the hospital charge. And that's been viewed by some as a more convenient mechanism for consumers and a potential way to really lock down the charges and not have anything billed outside of that. But it's a more disruptive way to the current status quo, and so it hasn't really gained much traction. There have been a lot of states that have addressed this, and this is our newest update. We'll actually be publishing this either later today or in the next day or two, but you're getting an advanced look at it. And you can see here there are now 13 states that have what we consider comprehensive protections. They do all the kinds of things I talked about before, and then another 14 states that have at least some protection but is not as comprehensive. And I think one of the nice things about this map is that you see it's a It's a mixture of what we think of as red states and blue states. They're different parts of the country, and they do use a variety of solutions. The newest states to join this map have been Washington and Nevada, and then Colorado, New Mexico, and Texas just this year improved what they've done and moved themselves to the comprehensive status where they had a less comprehensive approach before. And then finally is sort of like, why are we talking about this as a federal issue? Well, there are a number of gaps that people raise about what states can do. The first of those is on that map, you saw 23 states that were shaded white, 23 states where there is no law. And so a federal law would make sure that there's a standard across the country and doesn't have to wait for each state to decide to act. Secondly, and maybe most importantly, states don't have jurisdiction over the self-funded plans. And about something like 60% of people with employer-provided insurance are in those self-funded plans, usually large employer plans, and those are subject to only federal regulation under the ERISA law, and states are precluded from being able to address those. So when those states addressed balanced billing for their states, they were not able to do so for the self-funded plans. A third gap in what states can do is air ambulance. Mark mentioned that as an issue as well. Air ambulance is something that states are explicitly prohibited from addressing by the Airline Deregulation Act. And so for any kind of means of addressing the air ambulance issue, and while that's not something that hits a lot of people, when it does, it's a pretty big price tag, is something else for the federal government. And then one we've been hearing about a little more lately is services that are received in another state from your home state. And so when Washington State passed their law, they said, well, what if somebody from Washington is getting a service across the river in Oregon? And they actually call for some measures in that situation, but it's really only a federal law that could take care of that. And then the last point I'll make about the federal role is how do you sort of intersect what states are already doing with federal law? And there's been a lot of provisions in some of the federal proposals that we've seen to defer to state laws. And I think there's, again, some more detail to be thought through in that and something we can come back in questions. So with that, I'll stop.
Great, thank you so much. And now we'll hear from Frederick Isasi, who is the Executive Director of Families USA.
Thank you so much, Sarah. Thank you so much, Jack. We've got some national heroes here on the stage. It's great to be up here with them. So a lot of my presentation is just sort of reinforces what Jack just talked about. So I will move fairly quickly. For those of you who are not familiar with Families USA, I think most everybody in the room probably is. We are a leading nonpartisan national voice for healthcare consumers. Our mission is to ensure the best health and healthcare are equally accessible to every living soul in our country, period. We're funded through philanthropy. We only work on behalf of the interest of families across the country. We've been working for almost 40 years. We work on the state level, so we're actually working in some states right now trying to change laws around surprise billing, prescription drugs, other things. And then we've worked here in DC for a very long time. And we've got some staff here. Hey, staff, wave your hands so people can see who you are. The smartest person on this issue that I know is Claire right there. She just waved. So we've got some terrific staff. We are here to help you in any way we can. Reach out anytime. We literally are here to serve your interests. So just come talk to us whenever you need to. I'll cover three things: the problem, impact on families, and then some key principles. And they occur when consumers are charged through no fault of their own. So we're not talking about an instance where a consumer says, you know, I really want to go to this doctor. I know they're out of network. Let me figure that out. This is where you've done everything you could to make sure you're in network. And let me just give you two really clear examples. One, of course, is your insurance company, right? One of the ways they market to you is they say, guess what? GW Hospital's in network, right? So, okay, well, and often this happens with the employer. They'll sort of sit down and they'll build their networks and they'll kind of market that to say you should enroll in Blue Cross Blue Shield because we've got great networks. Georgetown Hospital's in network, right? You're out biking, you hurt your leg, you go to the emergency room, you're like, I know GW's in network. You go there, you get care, and you find out the entire emergency department, all of the doctors working in the emergency room are actually not employees of the hospital, and they're under a totally different contract and they're out of network, right? That's what we're talking about. Another example would be you need to get surgery. Let's say like I had arthroscopic surgery on my knee from a skiing accident, found my surgeon, thought he was gonna do a great job, he's in network, we're going, you know the hospital's in network, you go get your care. In the middle of surgery, he has to run a little test to make sure he's gotten everything he needed to get, right? It could be an imaging scan, it could be a lab test, and he sends it out it comes back, you get your care, you leave, and then you find out that radiological exam or that laboratory service is out of network, right? It's a little bit preposterous. And I will say, I've done a lot of work in previous life in industry working on these negotiations. The thought that insurance companies and providers think it's reasonable to not reach agreement and then just sort of leave it up to the consumer to figure this out on their own is totally unconscionable. And that is why we are here. Because it is not fair for an insurance company to say that GW Hospital's a network, but there are no ER docs there you can go see, right? That's a totally unreasonable position. And it's unreasonable for GW Hospital to say that they are a network and know that their hospitals, that their physicians are out of network, right? That's what we're trying to solve here. It's totally bipartisan. I mean, I testified in the House, and we had Republican legislators who, when they were in the Texas House, worked on this issue, right? This is not a Democrat or Republican issue. It's totally bipartisan. More stats, 1 in 5 emergency department visits, about 20% of lab services, and nearly 7 out of 10 air ambulances are out of network. This is kind of a dot diagram of the prevalence. As you can see, it's ER, anesthesiology, emergency services, and on this thing like labs, radiology, anesthesiology, they're often referred to, economists will refer to them as auto referrals, meaning you, as a consumer, don't pick who your anesthesiologist is. You pick your surgeon, you pick your hospital, you don't pick your anesthesiologist. So there's no competition, there's no market, and when they say, I'm not negotiating, and I'm gonna come back and charge whatever I can, that is a distorted market. They are leveraging a distortion to get a price that is not competitive. They're just leveraging their ability because it's an auto referral. You're not selecting them. Financial impact varies greatly. On average, it's about $600, but it can be as high as $20,000. In particular, air ambulances can be devastating, $10,000 for a ride. This is a chart of all the different, it's public opinion, and the first one is how worried people are about medical bills. And I just want to make a point, and you can see that everything from housing to utilities, and the #1 issue that Americans are concerned about is unexpected medical bills. In fact, in this country today, the American Psychological Association did a survey. They found more people are worried about the cost that they will incur if they get sick than actually getting sick, right? I'm more worried about having to pay for the cancer than I am getting cancer. And that's really what this is about. So let me tell you a really quick story. This is Sanji. She testified a couple weeks ago. She's she's the woman with brown hair in the corner there. She's from Englewood, Colorado. Do we have any Coloradans in the audience? No? Okay. So she lives just south of Denver in a little kind of storybook town. That's her husband, Nathan, her 2 beautiful daughters, and then her youngest son, Thomas. And they live in this little town, Englewood. It's about 30,000 people, known for its parks, for its reservoir, for its water parks, right? It's got the largest mall in Colorado. With the birth of Thomas's second, the sister that's closest to him, who's the young one with the glasses, they received a surprise medical bill. So when Sanji got pregnant with Thomas, she and her husband, Nathan, were like, we're gonna get this right this time. So they talked to their insurer several times. They talked to their doctor. They worked through the whole thing. They were all set. Her pregnancy came to term. She started going to labor. Here we go. They go off to the hospital. She starts to give birth to Thomas, and then everything starts going wrong. By the time he was delivered as a tiny infant, he was in crisis. He was bleeding out. And they discovered that he was born with hemophilia. And he was very, very close to dying. And so they immediately rushed him from the delivery room to the NICU, to the neonatal intensive care unit in the hospital, which was just down the hall. They were terrified. Their little baby was, like gasping for life. And after a lot of uncertainty, he began to stabilize. He turned the corner. Eventually, they could take him home. They had that moment where she could take him in his arms, take him home, and they could start their life together as a family, right? So it was a beautiful story of our healthcare system actually working. But then, a couple months later, the joy turned to misery in that they received a hospital bill for $50,000. As you guys know, almost half Americans have less than $400 in savings, right? So a $50,000 hospital bill just blows apart your entire life. The insurance company, before they went in, they had worked through every detail, and they said, your cost sharing will be $250, Right now, it turned out that the insurance company was wrong because it was $250 per person, and little Thomas counted as a person, so it was actually $500. But that was going to be their maximum out of pocket was $500. And they found out that that NICU, that was literally 50 feet away from the delivery room, was out of network, right? And this is what Sanji says. What happened was they refused to pay the bill. They went through enormous amounts of trouble. Their insurance company could do nothing for them. Eventually, this was settled through a class action lawsuit because they were not the first family this had happened to. But their credit was completely ruined, and they're still digging out from the fact their credit was ruined over a decade later. Sanji says, when you are told that your baby is bleeding out and his body lacks the ability to stop bleeding and that he needs immediate specialized treatment, your first reaction isn't, gee, I wonder if this is in network. Your first reaction is, by all means, do whatever it takes to help my baby. I would never have thought to check if the NICU, just 50 or so steps from the room I gave birth in, was in network. I think any reasonable person would assume it's a B because it seems reckless and cruel to me that it would not. So that's what we're talking about here. Going on, we have a few principles that are very much like Jack's. The first one is hold the consumer harmless. As I said, the last person in this whole scenario who knows what's going on is the consumer. The hospital knows, the insurer knows, the provider knows, the person doesn't know. They need to be held harmless. So in emergencies and in network facilities, balance billing should be completely prohibited. Balance billing has to be protected across all provider types, so not just emergency services, but whenever you're in that in-network dynamic. For out-of-network care, individuals should incur, due to no fault of their own, they should not pay more towards their care than they would have in-network cost sharing. Cost sharing amount should count towards a consumer's in-network out-of-pocket maximum, so make sure you're aligning everything. If I paid this money for this bill, even though it was out-of-network, it counts towards my out-of-pocket maximum. For provider types, when a consumer may reasonably choose to go out of network, such as office-based care, surprise billing protection should trigger unless the provider has informed the patient 7 days in advance of such service and the provider's network status with an estimate of cost and obtained patient consent. As you guys know, I mean, who here is trying to figure out if a provider was in network in their life? Raise your hand. How many people felt like that went really smoothly? Keep your hand up, right? So we have to make sure that if you're trying and you get bad information, you're held harmless. And this is really, really important, it's not just about your out-of-pocket experience, right? It's also about your premium costs. So this shouldn't be an excuse for providers to charge astronomical amounts of money. There's a lot of discussion going on right now. Should it be arbitration? Should it be average in-network rate? Should it be Medicare? Family's position is very clear. We are supportive of all three approaches. We think that average in-network rate is the right answer. But the one thing for sure is the fact that providers and insurers can agree should not be stopping Congress right now. Congress needs to act. So don't let that issue stop us from getting this done. And then 3, coordination between state and federal laws. As you guys have heard, the vast majority of Americans get their health care through employer-sponsored coverage. So for those of us who do, whatever our states have done doesn't protect us. It's only Congress that can act to protect us. So we need Congress to act. We would say use a HIPAA model. So if the state has passed stronger laws, let the state law preempt. But if the state hasn't passed any laws, the federal law has authority. And then even, as I mentioned, make sure ERISA is covered. And that's it for me. With that, I'll turn it over to Al.
Thank you. Good afternoon. A pleasure for me to be here today. I will put the disclaimer about this. My views here are not necessarily those of Wakley's. I also want to thank a couple of my colleagues with whom I'm studying this issue right now under some research. We are not totally finished yet, but we have researched at least a small piece of that, and that's mainly what I'm going to be speaking about today. We'll go right onto it. I have come up with about 4 categories. We could probably debate how many there are. These are all areas where you can see out-of-network bills, and the one that I'm going to focus on, which is really, in my opinion, the smallest, is the in-network surprise, what I call the in-network surprise, which you've heard a lot about so far, and I think that's really what you see a lot of in media and what people talk about. But all of these can certainly involve balanced billing. All of these are contributing to increased healthcare costs to the extent that the providers and the insurance companies are not under a negotiated rate. Unless it's negotiated after the fact, it's not under a contractual rate. And I'll come back to talk about some of these in a bit. Insurance companies have put together networks for a number of reasons. Part of it is to help control costs and also to control cost increases through the contracts that they have with providers. And usually, almost always, the benefits that someone has when they purchase one of these plans or are covered under one of these plans have incentives to use in-network, and they can be fairly substantial. As you've heard the examples of today, the surprise occurs when someone's done everything they were supposed to do, including once or twice to myself. And then they get this bill, usually, as you say, 2 months or so after the fact, not expecting it, and it all of a sudden is a whole lot more than they researched on their cost sharing. So we're talking about people who have actually intentionally done what they thought was the right thing to do to minimize their out-of-pocket cost. But then they get this bill, and even after the insurance company maybe has negotiated or paid a reasonable customary charge or however they manage to do it, there's potentially balanced billing to go along with whatever cost sharing there was under the allowed costs. So, and as we talked about, it's usually a situation where it's the hospital has a contract, or maybe it's the outpatient facility has a contract with the insurance company, but the providers do not. Now, how prevalent is this? You've seen some statistics already. Another article I read just last week says that even these types of physicians that were on the previous slide are only about less than 16%, and not all of those are going to be out of network. But we have access to a national database of claims data. It's the IBM Watson Health market scan data. Now, it is insurance claims data, so it is somewhat limited. It has a lot of it is self-insured, but it's going to include allowed costs. So allowed costs are what's ultimately been negotiated or paid or determined to be allowed and adjudicated by the insurance company. But part of this database allows, it has an indicator as to whether the claim was in-network or out-of-network. So we went through and looked at out-of-network physician claims, and this is allowed costs, not paid amounts, but out-of-network physician claims that were associated, or that the timing was such that it was obviously associated with an in-network facility stay or visit. And you can see the numbers are pretty small as a total percent of all allowed costs. But that doesn't mean it's not an issue, because even though the totals are small, these are averages. And in these averages, you've got some systems where essentially there are no out-of-network costs. You go to pretty sure this is true, you go to a Kaiser facility in California, and you're not going to have an out-of-network surprise bill, even though sometimes in Kaiser coverage you do see them if you go to a certain emergency room or something. So that's a pretty small percentage of all costs. So providers in general are not going to be taking a huge hit when you're talking about fixing this problem. And premiums for this part of the surprise bills are not going to change that much, although they do change some. And when you start adding in the other pieces, as you'll see, it's going to be, not an insignificant impact on premiums. Now, as I said, there's some considerations. This varies tremendously by issuer and type of issuer, and even by network. And even for certain types of issuers, it might vary within a state, within areas of a state. And it's because, as you saw, there are some states that have a huge percentage of facilities where, say, the emergency room physicians are not in network, not under contract. They may be under contract with the hospital, but not with the hospital's insurance companies. It not just varies within a state, but I mean, there's certain parts of the country where this is far more prevalent, as you saw on the slide earlier. But there are large differences in out-of-network costs, and you saw some of the statistics that my colleagues here have shown you. And the distribution is big. When you start looking, I mean, there's not one number, and averages can be real deceiving here. So even though it's not a significant percentage of total costs in our system, assuming that this database represents our system, which it doesn't, it's not universal, but there is obviously significant cost to the enrollees. So addressing this, what the in-network surprise, is not going to have a huge impact on average premiums. It may have a very big impact on some premiums. You saw the slide that said for one issuer it was huge, whereas a couple of other issuers in the measured state did not have as much of this issue. So it could be big when you get away from averages. But when you start adding in the other pieces, the ambulance, the air ambulance, the out-of-network piece, just going to an out-of-network provider, which, by the way, I think I neglected to mention, sometimes you go to an out-of-network provider and they refer you to, say, an imaging facility, which is also out-of-network and may be partially owned by that provider. It's been reported that some of the proposals that are running around out there and that you all are considering could have as much as a 2% premium savings when you add all this together. And from what I can tell so far, I could easily see that. Now, I'm not going to get into what you should be doing, but there are some ways to solve this. I mean, some things I've heard personally are discussions around requiring that any hospital that has contracted physicians, anytime they sign a contract with an insurance company, then that contract would have to be including those contracted physicians. And then you've also heard about the other pieces, the percentages of Medicare, the median or average in-network reimbursement or arbitration. Any of those would go a long way toward fixing this. Arbitration, probably less certainty, certainly, for the enrollee, but any of this would be a help. So with that, I guess I'll turn it back to
All right, thank you very
Sarah.
much, all of you, for your remarks. So we're going to get started with some questions. I obviously have many of my own, would love to hear yours as well. You all have green cards in the middle of your table. You can write questions on those. I believe there's also 2 microphones on the sides close to the back if you want to stand up and ask your question. And you could also tweet your questions with the hashtag AllHealthLive, and people will be keeping an eye out for whatever comes in that way. And with those green cards, I believe people should be coming around to collect those. If yes, Sarah's over there and happy to come do some green card delivery. So I'm going to bring it back, probably start with you, Jack, about some of the state laws that you spoke about. I was curious, are there ones that, as Congress is thinking about this, obviously looking for as much information as they can, are there certain states, certain approaches you think have been especially successful? And what are the key lessons kind of you would take away from how to make these work or potential pitfalls they've run into that federal legislation could avoid?
So it's a great question, and it's one that we get asked a lot. And part of the challenge is that a lot of these state laws have only a very short shelf life. They've only been passed in the last couple of years, or they've been modified. Texas, for example, has had a law in the books for a decade, but they've modified it a series of times, including in this most recent session. So when you try to look at, what's been the experience in a state like Texas or California, it's challenging because of the recency of doing things. There are things we can learn. I think one is that states have crafted different solutions to fit the circumstances in their states. So markets vary. There's different amount of power with insurers in some states, with providers in other states. And to the extent that all of this problem is about market failure, obviously in an ideal circumstance, networks would be adequately inclusive. There would be circumstances, the physicians that practice in Hospital A would also belong to the same insurance networks as Hospital A. But where the market fails, that's where we see these efforts. And so states have looked at their particular circumstances and have tried to deal with it. A couple of things I would mention. One is some states early on looked at the possibility of having sort of an informed consent model. If we tell you about the possibility that you might get balance billed, and if you sign something that says, yes, I understand that's a possibility, then it's okay, then you go on and get the balance bill. The problem states have realized with that is that it becomes one of those many pieces of paper you sign when you encounter the healthcare system. It's one on a clipboard and you're told, sign all these 8 places. And you're not going to be able to understand that, let alone if you're already being admitted to the hospital that morning, it's a little late to do that shopping for, is my anesthesiologist in network? I think states have also seen more of the problems with solutions that set rates based on charges, because that tends to be inflationary. Charges can be several multiples of what insurers typically pay or what Medicare pays. And so a charge-based system tends to create higher rates and doesn't have the sort of cost savings effects. Some of my colleagues did a study of the New York State approach, and I think have found that things have worked pretty well there. And I think that's what you tend to hear is that when you talk to stakeholders, as a whole, these things are fixing the problem in the sense of addressing the concerns that consumers have, except for all the obvious gaps that we've already talked about.
Yeah.
And of course, it wouldn't address the self-insured plans.
That's right.
Right, so for most Americans who get their coverage through their large employer, we're all of us just hanging out there right now until Congress acts. I will say this idea that a patient can be informed ahead of time, you might get a surprise bill. Just think about it, in Sanji's case, she would have gotten a piece of paper that I'm sure said something like, as a former lawyer for hospitals, something like, I understand that there are services provided in this institution that may be out of network, and I'm willing to, assume financial liability for those services. Do you honestly think that Sanji, she would have thought, well, maybe I'm getting, if I want to get a facelift, I'll have to pay for that out of network. But a NICU, a NICU in a hospital that's providing obstetrics and gynecology, really? So that feels like a giant loophole. It doesn't address the problem at all. And the second thing I was going to say is on charges, guys, just remember, it's all very confusing because there's charges and there's price and there's total paid and all that sort of stuff. Charges is, in essence, when you go to TJ Maxx and they have manufactured suggested retail price, the MSRP, it's the made up price that they're putting on this pair of underwear, right? I should be paying $50 for it, but they're only charging me $10, what a deal. That's what they're talking about. It's their manufactured suggested retail price for my anesthesiology services, right? That's a preposterous place for us to start to try to find a reasonable price to pay.
I remember actually I had a baby about a year ago, and when I was there, I was trying to avoid signing the paperwork. It did not work out in my favor. And so I did not end up with any surprise bills, but it was, while you're in labor, it's a very hard time to negotiate around paperwork. So we've got a lot of questions, and thank you so much for everyone who's sending them up here. I'm reading through all of them. And we have a handful about the actual kind of heart of the policy solution. How do you figure out what is a fair price when an insurance company and hospital don't agree? And I'm gonna read you guys two versions of that question and love to hear your answers. One is, what are the pros and cons of benchmark rates or arbitration as potential policy solutions? Another is, can you speak to some of the concerns with rate setting and how the various legislative proposals address this?
I can start on that. I think, the pros and cons are numerous. And for rate setting, I think the The best feature is that it's a clean number. We know what it is. It gets you to the point. If it's set correctly, and again, rate setting that was set based on 80% of charges, which has been used in some cases, is not necessarily going to get you these results. But rate setting that's set based on 125 or 140% of Medicare, or based on the the median in-network rate, some of the things we've seen out there, can get you not just to a rate that's clear and understandable and therefore easy to administer, but also one that does not lead to healthcare cost inflation and could even lead to savings. In many cases would lead to savings. The problems with rate setting have been more in the reaction of stakeholders. Providers have objected to rate setting, I think partly because they feel like it's a starting point towards overall kind of government rate setting and something that therefore they're not happy with. Obviously, rate setting, in my example of charges, if done badly, could have other kinds of adverse effects. If I said rate setting was at 25% of in-network rates, that could create problems in the other direction. With arbitration, I think the biggest concern is that it is a more administratively burdensome process than a rate setting. It does require parties to come to the table. There's some cost involved with that. I think there are ways to keep that cost somewhat under control, but there nonetheless is a cost. People have talked about costs in the range of $600 to $1,000 per case. And of course, if you were talking about a $100 charge, that's not going to be appropriate. But in a way, that's what should minimize the use of arbitration if it were seen there coupled as sort of an appeals process for relatively infrequent use. So I think you can really get into a lot of those issues over the different advantages and disadvantages. A lot of it depends on the circumstances and whether you're trying to come up with what you think is the best solution, all else being equal, versus something that gets to the point that we've already heard made up here. We've got to get to the point of trying to solve this problem for consumers. So if we get into the art of the political, that's where you start to look at give and take among some of these different approaches.
I was just going to say, just really important, this issue of not being able to reach agreement between the insurer and the provider is literally the reason we have balanced billing. It cannot be the reason that Congress doesn't act, right? We have got to get past this. This is why you guys all work for your bosses. I mean, this is the point of having elected officials. We got to settle this and move on. America's families cannot get a $50,000 bill when they deliver a baby. That's not any way to provide financial security to our families, right? In terms of the concern here is, as you guys probably know, the negotiation between insurers and provider is one of the most intense, sort of highly scrutinized negotiations you can imagine. I was part of this in a previous life a little bit. And the concern is you set a rate at a certain place and you put your thumb on the scale towards either the insurer or the provider. And that's the concern, right? And so there's three main approaches you've heard about. One is it's kind of a bundled payment approach. I'm going to pay a hospital. Like if I show up at a hospital to get surgery, I'm going to give the hospital one payment. The hospital can pay the surgeon. The hospital can pay the anesthesiologist. The hospital can pay the laboratory services. That's what I've read, the economist's favorite. It's very clean, it's very elegant, but it's a whole new way of doing business that can be a little bit hard to get going, right? The second one is this idea of allow for arbitration, right? So just let the parties come in and fight it out, and it's baseball style, so I'm not going to split the difference. Whoever has the most reasonable approach, that's what I'm going to give you. And then the third is let's just pick a rate. Now, the beauty about picking a rate is everybody knows in advance this is the situation. There's no surprise. There's no fight at the end about what the payment rate is. We favor that because we think it's the easiest to enforce. We will make sure that families actually don't get stuck with a crazy bill. However, I will say this. When setting the rate, okay, there's a few different approaches. There's charges, which, like I said, is crazy. That's the manufactured suggested retail price becomes the price. That's insane. The second is use a Medicare benchmark, right? 120% of Medicare. Medicare is right now the only program, really the only place we see in this country where people actually try to figure out costs and then set a payment based on that. But then the third is one that's more market specific, and that's where we've landed, which is the median in-network rate. So it's sort of what's the average that's getting negotiated by the providers in this community. And that's what we favor. I will say, if you think about the statistics that Jack put up there, in Texas, right, what they found was if you were in United Healthcare, 40% of the ER visits were going to be out of network, potentially. If you were in Blue Cross Blue Shield, only 18%. And if you're in Humana, it was 63%. Now that, to me, is a warning sign, right? We care about both sides of this. We want to make sure people have access. What does it mean for Humana to say that they have adequate networks in Texas, but 37% of, only 37% of the emergency rooms are actually in network, right? So there are two sides to this argument. We think the most elegant, simple solution is that median in-network rate, which is responsive to the individual market in which it's being negotiated.
I would say that, you know, you look at arbitration, and unless the fix also sets something like in-network cost sharing for the enrollee, the enrollee still doesn't know how much they're going to pay, right? So you haven't really totally solved a surprise bill issue, at least the in-network surprise as I call it. I would agree a charge-based system is problematic. One of the things I mentioned is that in-network provider rates have oftentimes a limit on how much they change from year to year. There's no such control over, or no such control or limit when you talk about charges. And so, when we're trying to do things about healthcare cost increases, a charge-based system is not going to help solve that.
I would just mention on one thing that Texas did in the new law they passed this year is ensure that if a higher amount is established in an arbitration process, the patient's coinsurance, if they have a percentage-based coinsurance, would still be based on the original in-network rate. And so there are these tweaks that states have found, and I think that's another place where some of the lessons.
And I think that's important.
Incredibly important. It's one of our principles. It's incredibly important that if you thought you were network, you have an in-network experience with regard to your cost sharing, and it applies against your limits, and you will have an in-network experience as an enrollee.
I'd also like to give a plug to we just posted this morning on Health Affairs blog and something that does write up more about the pros and cons of these different approaches, so refer you to that for more.
Well, let me ask, we've talked a lot about the possibility of some kind of rate-setting solution, and a few questions have certainly come in about some of the challenges with that. If you have more questions, feel free to write them down. They'll be handed up to me, and I'll remind you, there are also 2 microphones if anyone is brave enough to ask their question in person, but I'm happy with the green cards as well. So a few people are asking a little bit about how a rate-setting mechanism would work, and one comment we received is physicians would say that limiting reimbursement to average in-network costs would discourage insurance companies from negotiating in good faith with physicians. Another question is that, is it expected providers impacted will raise rates across the board, maybe look for new ways to make revenue if they have some of these restrictions put on their billing practices? How do you think about how having these contracted rates, is there anything we'd learn from the states, how those impact the negotiations between insurance company and hospital and doctor?
That one surprises me a little bit. I mean, to have an average or median in-network rate, there has to have been negotiations and contracts with in-network providers of the, for example, in-network emergency department providers. So I don't know that it would discourage the negotiation, because the whole emphasis or the incentive is to bring as much of the care in-network as possible. So I may not understand the question, but it doesn't seem to me that would discourage the negotiation at all.
Yeah, and I don't think you're misunderstanding the question. I think this is what we keep hearing from particularly ER docs who are the ones who are most impacted by this. Think about what they're saying. So right now let's say I'm in Texas, right, where 37%, I'm a Humana, 37%, only 37% of the ER care is being provided in network. So a bunch of it's out of network, and I can charge whatever I want. By using median in-network rate, what you're doing is you're internalizing those costs down in the negotiation. And remember, it's median, so there's folks who negotiate higher, and there's folks who negotiate lower. So instead of those doctors just sitting outside the negotiation and just charging whatever they want, they now have to come in and negotiate. And that's going to create a price that actually reflects the needs of that community. Now, I will say, and you see this in the Health Committee bill, we need to know what the networks are. We have to make sure that there's adequate networks, that consumers are getting good information about who's in and out of network. Those are all pieces that all have to fit together. And we are ready to fight with the ER docs if, for example, the networks aren't adequate, right? So it's not just set a payment rate that represents the median in-network rate, but it's also make sure that there's real, robust networks that allow individuals to have access to the services that they need.
And one of the things you've seen, I think, both in some of the federal proposals and certainly in some of the state laws is linking some of these different solutions, benchmark rates or whatever, to other sort of transparency and network adequacy and network information. So you saw provisions in the Senate Health Bill and the Energy and Commerce Bill to make sure that network provider directories are accurate. Now, it's not always as easy as just saying they must be accurate as to actually translating that, but it's at least pushing that discussion in the right direction. And some states have linked this specifically to network adequacy requirements. So I think, it is, this is a multi-piece kind of thing. We can sort of fix this issue, address some of these things. It doesn't mean there doesn't have to be increased attention on guaranteeing that networks are adequate, that people know who's in network. And one of the challenges is the fact that it is hard, we've already talked about this, it is hard to find out for sure if somebody's in network. Yes, I take Blue Cross. Oh, do you take this version of Blue Cross? Oh, well, I'm not sure. Let me go look it up. Oh, no, it turns out we don't take that version, we only take this version. And that's the challenge that people face.
So I want to ask you about one conversation I had in my reporting a little while ago that I'm reminded of, and this was in reporting the story about Scott Cohan. He was a person who went into the Austin hospital, ended up with an $8,000 out-of-network bill from his surgeon, who it turns out was an oral surgeon, wasn't in network with any, he just did not contract with health insurance plans. When I talked to the hospital about this, their perspective was, look, there aren't a ton of oral surgeons in the world. We need someone to staff our emergency room, and one of the ways we get someone in there is we let them bill how they would like to bill. He was posing the question to me, well, do you think it would be better if we just didn't have an oral surgeon on staff here? So an argument I have heard a lot from hospitals in my reporting is that we need to have these services. We feel like we don't have leverage in these. You're very ready to say something.
So ready for this.
What do you think about, what do you think about concerns of erosion of access to services?
Right. Listen, if there's any group in this nation who cares more about access, it's families, right? So we are 100% on board with that concern. Here is the thing. For a hospital to say that, basically what they're saying is, we can't figure it out with the oral surgeon. So when you go get your service, we'll figure out what happens, and you're gonna get stuck with a terrible bill, right? The point is, they should be forced to sit down with that oral surgeon and have the conversation and negotiate, have him or her come in as a network provider, and then we know what the costs are and you have protections. The thought that the only way you can staff is by letting it be the Wild West where people can charge whatever they want is preposterous. There's no reason why that same surgeon, they couldn't sit down and negotiate. And by the way, it is a market in that sense, right? And eventually you reach a price where you attract more surgeons and more people show up. And what they're basically saying is, I'm a hospital and I want to be able to provide oral healthcare surgeries, but I'm not going to be responsible for actually making sure that we have a provider who can do it. That's a preposterous position for a hospital to be in. And by the way, an emergency room, an entire emergency room, a NICU, there's a business model behind this in many cases. Like having a NICU be out of network is basically saying, we figured something out. It's an auto referral. When that baby is born in crisis, you get to take care of them without anyone making any choices. That's an auto referral, and I'm gonna charge whatever I want. That is a business model. That is not about access. That's about a business model.
But do you think there's a fair worry about the oral surgeon saying, you know what, I have a booming, outpatient practice. This just isn't lucrative. And is that an okay outcome? If there isn't an oral surgeon there sending $8,000 bills? Because I think about it from the provider side, the incentive isn't quite as strong to work in the hospital when you can't bill whatever you'd like to bill.
Except that we know that provider showed up to practice in the hospital because she did or he did, right? So there's a price that is available that will attract that provider in the hospital. Let's force the much more sophisticated negotiator to go through that process and not just have the consumer at the whim of whatever the surgeon decides. And by the way, in Denver, in the Denver area, when they looked into another case of surprise billing, they found 120 homes in that area that all had liens on them by ER physicians who'd gone to a collection agency and were basically trying to take people's homes away from them for paying their bill. Like, this is crazy.
Yeah, I mean, I think one of the things you have to remember is that, you know, how this issue has evolved over the years. Hospitals, and Frederick was just talking about this, have made a business strategy, or not necessarily the hospitals, the physician groups, so groups like MCare that have come in and done hospitals a service by saying, we're going to staff your hospital's emergency department. You're not going to be the one that's on the line to go out there and make sure you have 24/7 coverage. So that's nice. That's a good business relationship. But the problem is a lot of that has been premised on companies like MCare who make their business model based on out-of-network billing. They know that they can get this extra revenue by billing the patients beyond what insurers will pay. And you know, a slide that I've used in some talks, but I didn't fit it in here, shows that hospitals have gone from 0 out-of-network bills to 100%, like a light bulb turning on as soon as they bring in this company. And I think what's important in the oral surgeon case and the NICU case and these other kinds of cases is to remember, these are emergency services. This is not the market working, you know, if I want to go in and have oral surgery on something that's discretionary, I want to get a knee replacement, I can go out and shop for surgeons. You know, a market will develop, prices will develop, those things can happen. But in emergency, that all goes away. I come in, I'm brought in by the ambulance, I'm sent to the baby is sent to the NICU, the oral surgeon gets pulled in the emergency to deal with the situation. If it's a situation where that oral surgeon could wait a month to happen, or the surgery could wait a month, then you could go around and do business and shop, and then you can make a different set of arguments. But when it's happening under no control of your own, that's why this is a policy issue that feels like, and yes, there's a real concern about access implications, and I think we do need to talk through what different rate formulas and things will mean for access. But in the end, we got to make sure that a patient is not being caught in the crossfire in these situations, that they are just coming in to get the care when the emergency happens and doing all the subsequent things that happen to them, NICU case, ER case, whatever it may be.
Hi, Joyce Frieden with MedPage Today. In all this discussion, is there any way to talk about what is happening now? With all of these out-of-network charges, are 100% of them getting paid? I mean, I know, you know, Frederick mentioned the woman who's, you know, they're still digging out of bankruptcy. Are some of these getting settled? Are there any statistics on how out-of-network billing, how successful it is now?
It's tough to have those kinds of statistics because a lot of the settlements, you know, Al talked about looking at the insurance claims. Well, whether something gets sent to a collection agency, whether there's an agreement between the provider and the patient on how much they're going to collect of the balance bill,
Right.
whether that's done amicably, whether that's being done through a collection agent, is not something that generally shows up in the insurance claims. And so we're really challenged to try to come up. I think one of the kind of case that gets settled the most often is when it gets in the media. So when Sarah starts writing about it and asks questions, if you start writing about it and ask questions, there's a good chance it gets settled.
We should all have Sarah on speed
Yeah.
dial.
It's not a very scalable
But
solution.
it's not, exactly, it's not a scalable solution.
Right.
And, you know, in the old days, I like to say that, you know, if we were looking back a couple of decades, almost all of these cases got settled. The local insurers knew the local hospitals, knew the local doctors. The guys settled it on, you know, it was all guys then, right? They settled it on the golf course or over a drink in the bar. Oh, let's just take care of it. You know, we'll split the difference. That was nice when that worked. That doesn't work today. And so I think as the relationships between insurers and providers have become more contentious, yeah, a lot of cases still do get settled. I talked to somebody about, you know, sort of how things have played out in Texas. A lot of the cases that have come in go to some kind of informal discussion and just people work things out. They get a sense of what a reasonable rate is going to be, what an arbitration might lead to, what the rate setting rates, and they say, hey, let's agree on this. I'll go, you know, 10% above that. I'll agree on, let's just get it done and get it over with. Sure, those happen a lot, but can we count that that's 10% of the time or 90% of the time? That's what's more challenging.
Yeah, and it's going to vary by issuer too. So you're right. I mean, let me give you an example. A lot of issuers will, let's say someone is out of state and they go to emergency room, they get admitted to the hospital from the emergency room. A lot of issuers will, as soon as they hear about that, begin calling up the provider, the hospital, and starting to negotiate the payment. So ultimately, a lot of these things there are payments made, but but that doesn't necessarily mean that you won't have a situation where the enrollee, the patient, then gets additional billing.
Right.
And then you get into things like, what you just talked about with housing liens and whatnot.
And they're also with the self-insured companies. I know people who've hit surprise bills. They're employed. They go through their employer for their insurance, call up the HR department. Maybe the HR department figures out how to, because they want to protect their employee, but they may do that by paying the full charge. And then that gets added back in the premium next year. And so sometimes they get settled, the consumer gets protected, all right? The consumer gets protected from that bill and doesn't end up paying that $20,000 bill or that $1,000 bill. But guess what? If the self-insured company is paying that amount, that's going to be one of the factors that's factored into premiums next year. So, there's just a lot of layers to how this plays out.
We've talked a little bit less about arbitration as a policy solution, and I know you all know New York has had its law on the books for a few years. I believe New Jersey's law is pretty similar. Tell me a little bit about how you think about that as a possible solution. And we did have one question of, is there some kind of hybrid, a rate-setting, arbitration, working together approach? Is that something that you all think could be a potentially positive solution?
I mean, there are arbitration systems in effect, and New York, as you say, is probably the one that's had the most publicity. New Jersey's is newer. There's a couple of the new states that just passed laws that include arbitration components. Florida has one, Illinois has one, a few other states, Texas has one as well. What the people in the states that have developed those say, their biggest hope for these systems is that almost no cases actually make it all the way to arbitration. That it becomes an incentive to work out a more informal deal. And the experience, and again, some of these states, New Jersey's is so new that we just don't know much yet. But in New York, where we do know a little more, my colleagues have put out a paper recently on it. Only a couple of thousand cases in the first several years have made it all the way to arbitration. They've been settled fairly equally between the two sides. A number of them have been settled through some other kind of mechanism and never go all the way to the end. And again, that's kind of the goal. But it does involve a cost each time. And so that's when we talked before about the pros and cons. The notion of a hybrid approach might not be, like my first choice of a solution. A solid, simple arbitration based on a reasonable standard might still be the best way to go. But as the politics plays out, whether in the states or here in DC, people have looked to hybrids as a way to sort of get to an answer that can get something passed. And so we've seen recently in Washington State and Colorado putting together different means of hybrids. So that you start with a rate standard. So in Colorado, they use something similar to what's been talked about here, an in-network rate as the standard, and then allow sort of an appeals process to go to arbitration in some cases. They've just passed that, so I can't tell you, how often. And you've got to remember that in Colorado, they had an old law that it was up to the insurer to hold the patient harmless, even if that meant paying full charges. And so, they're bringing this down to a much more sensible rate standard that's based on in-network rates, but gave providers the ability to appeal that rate. And some have suggested to me that if you have that kind of an appeal-style arbitration, you set up in a way that says, hey, the final answer could be lower or higher than the rate standard set. You're not guaranteed to get a higher rate because that creates an incentive for well, let's take it, because what do we have to lose? Well, you have to lose the cost of doing it, but you also might, if you set this up correctly, have the possibility that the arbitrator says, no, actually the insurer has suggested that there's this lower rate even than what the original standard that might make sense here, and I think that's the one to go with here. So it's like when you were in school and the teacher said, I'll look at your exam again, but I might find a lower score as well as a higher. So that was always my trick when I taught. I'll look at your paper again, I'll look at your exam again, but no guarantee you end up gaining points. You might actually lose points. And a lot of people said, oh, well, don't bother.
I don't know if I'd sign up for that course. I'm going to make we have about 10 minutes left. I'm going to make one last call if anyone has any burning questions to write them down, come up to our microphones, and we'll try and squeeze them in. One question I got, it's actually a question I have wondered as a reporter, is in the Senate and House proposals on surprise billing, why aren't ground ambulances included? And any thoughts on that particular space? I know you showed that slide showing that I believe 51% of ground ambulances are associated with an out-of-network bill. And it seems like air ambulances were just added into the Senate legislation. Is anything different about those two policy areas?
I think one difference that we've talked about is that air ambulances, states are preempted from acting. So that's been an incentive for the feds to go in and put that in their bills. With ground ambulances, and we've been trying to go back and look at what's going on in the state laws, and we think at most 2 or 3 states have addressed this at all, and I need to go back and look more carefully at those and see whether what they've actually done really does regulate it or whether it's something a little lesser on that. I think one of the reasons states have not tackled this, and perhaps this applies to the federal law as well, is that a lot of ambulance services are delivered by local government agencies. So, you get your ambulance through the city, through the county. And so it may be just more challenging. It's a different kind of system to work with. And I think to some extent states have said, maybe first of all, prove that there's a problem, and then we'll come back and deal with it separately. Florida actually took a fairly extensive look, and I might refer you to a report that the Office of the Insurance Consumer Advocate put out in Florida, which at least raises the issue, talks about some of the things you can do. I think the solutions can certainly look like they do with other services. You can talk about a rate setting issue and a ban on balanced billing. I think it's just probably more than anything else, it just felt like a different area with some different players involved, and people said, let's deal with the rest of this first, and then we'll come back to that.
Mm-hmm. Go ahead.
Hi, my name is Amanda Hunt, and I'm a policy analyst at Altarum's Healthcare Value Hub. And one of the things that I very seldomly hear in these conversations, and I think, Dr. Hoadley, you just mentioned it, is state-established offices of the consumer advocate. Connecticut in particular is an example that we have looked at very closely. And they have kind of these two functions. They provide direct assistance to consumers when they're having problems with any type of insurance whatsoever. And then they also advocate to the state legislature on their behalf. And so I'm wondering if you've heard of any other states that might have an appetite for this kind of solution.
Are you suggesting that in lieu of protections against balanced billing?
Not in lieu of, but almost
Okay.
in addition to. I very rarely hear that mentioned as like an additional solution.
Yeah, Florida, it has been an interesting office, and I've talked to those folks a number of times, and they do play that sort of dual role you talk about. They can take individual complaints, and they also, in the case of their original concerns about balanced billing, surprise billing, they did a year-long effort to sort of look into the problem, and they were the ones that sort of sent the proposed solutions to the legislature, and the legislature, of course, took it and tweaked it and did other things to it. And they've done the same thing with the ground transport. And so I think they can play an important role. I think the challenge, sort of a role as an advocate within the government to try to push for things, makes a lot of sense. The role of sort of dealing with the typical consumer's problem is pretty limited because most consumers don't know these things exist. Most consumers, I try to say when I talk about these things to any kind of a consumer audience or through the media is, one of the things you can do when you hit these problems is you can go back to your insurance company, you can go back to your provider and see what they're willing to do for you. You can go to your state insurance department, but I dare say that the average consumer is barely aware, if at all, that there even is a state insurance department, and certainly doesn't think of it as a place to go for help.
That's where I was going to go. In my experience on the state level with these kinds of groups, they're usually the ones calling for this legislation. They're the ones who are sort of saying, this is out of control. Consumers need legal protections, not just our advocacy, but the legal protections themselves.
Thank you.
Let me ask another question we got from our audience that I'm sure is one some of you in congressional offices might be hearing. The question is, while the percentage of Medicare that these specialty physicians charge seems high, a more sympathetic argument is that these physicians are compensating for uncompensated care they provide, especially in emergency and ambulatory settings. How important is this to consider?
I mean, it's certainly part of the calculation, and you know, first of all, there are a lot of other mechanisms to deal with that problem, you know, getting Medicaid expansion and other kinds of things that reduces the number of people that come in without insurance, obviously, is a more direct way of fixing those issues than sort of building the cost in for these people. I mean, you know, that's why this is a political process, to think about exactly what the right standard is. You can take these political factors into account, but the idea that they're paid for on the back of the consumer is the thing that I think all of us agree isn't the appropriate process. I think when Medicare establishes its fee schedule, it's looking at a lot of the aspects of what's going on, and the notion that physicians and other specialties are getting paid at an average of 128% of Medicare when they're dealing with their negotiated insurance rates, and yet these specialties are up at 300 and higher percent of Medicare, and their charges are well above that. Charges may be up in the 600, 700, 800% of Medicare range, suggests that something's wrong. And I'm hard pressed to think that the additional amount of uncompensated care they're getting makes that kind of numerical difference. Yes,
I want to say I really appreciate the question. We care deeply about making sure that we don't have uncompensated care, that we do have a rational system of health care. What we know in this country is in the last few years, a few things have happened. We've driven down healthcare utilization as a country. We have less stuff happening, and as a result, we actually are not spending less on healthcare, we're spending more because the price of healthcare has gone up so quickly. So this idea that that's a reasonable price, the data show it's the exact opposite. It's almost a 300% increase. We're talking about like if you bought your iPhone 3 years ago and it was $800 and you go now and it's $2,400, right? That's what we've seen in healthcare in this country. It's remarkable, and it's because of one thing, which is when we think about a doctor negotiating with an insurance company, we think of like, she walks in the room with the insurance company, and the insurance company's got a green visor on, and they're like, this is how much we're going to pay you. And listen, I'm no fan on either side here. I'm not trying to. Insurance companies have their own problem, but that's not the case. In this country, what has happened is we've had massive consolidation. So hospitals have consolidated. Physicians, the majority of physicians are now employed. So these are two big businesses negotiating with each other. And in a lot of markets where the providers have gotten so consolidated, they can just keep increasing price year over year over year. That's the most reasonable explanation for why there's such a big delta there. It's not uncompensated care is filling, they're trying to fill in the gaps.
Yeah, I have to think it's something more than the uncompensated care argument, because as you go back and look at what we found even with insurance data, it's there definitely are a lot of in-network emergency department physician claims. So obviously unless the folks have decided that they're practicing in a setting where they're more likely to have uncompensated care, I can't see that uncompensated care argument explains it all. So to me, there has to be more to it than that.
And I would remind you of that business model we referred to earlier of the companies staffing emergency rooms, statewide anesthesiology practices that basically create their own monopolies. And so there's a lot of the business.
And what they're not doing is providing uncompensated care.
Yeah.
You mentioned some of the concentration in the market, and one other question we got is, are there any possible solutions that involve increasing competition rather than price fixing for this type of healthcare, or is there something different about this particular type of healthcare where more competition is not going to solve it?
It's a great question. It's to my mind, what we want is competition. We want there to be a real negotiation between the insurer and the provider. When they're out of network, it's literally no competition. They just set whatever price they want. if you were to choose the median in-network rate, what you do is you force them to show up and actually negotiate with another sophisticated party to come to price. That is competition, right? So now the anesthesiologist has an incentive to show up and really fight it out. Let me be clear, the anesthesiology group that then has an umbrella group on top of it has a reason to show up and negotiate with that insurance company. That's a real negotiation. So creating a benchmark rate, particularly one that's responsive to a market, actually could incentivize competition, not the other way around.
And of course, we're trying to solve this particular consumer problem today. We're not trying to rewrite the entire healthcare system in legislation on surprise billing. We've got other
thoughts
to have
about
those discussions and another day. But on the same time, figuring out how the solution to this particular problem either points us generally in the right direction. In other words, if we base this solution on physician charges, we'll be pointing kind of in the wrong direction. If we can base this on something like in-network rates or Medicare rates, we might at least tilt this conversation in the right direction and say that we'll either get the right kind of negotiation or allow ourselves on a glide path toward having some of the right kind of conversations later.
I'll wrap up with one last question that's a little more about politics than policy. So one thing I hear from providers who are concerned about this legislation is they feel like they look at the possibility of some kind of benchmark rate and their mind jumps to single payer, rate regulation, government setting prices. How do you think about, if this legislation moves forward, do you think it, sets some new precedent for more government rate setting, or kind of stops there for this one particular area where people just can't be shoppers? How does this relate at all to the politics and policy of the single payer question that's coming up a lot in the Democratic primary?
I mean, I would say, politics is obviously everything is interconnected and things will relate. This is a solvable, smaller piece of the problem. Mm-hmm. Surprise bills are not the bulk of healthcare. They are the thing that people get scared of, but what people get scared of is a lot of other kinds of health costs, as you talked about. I think your example, Fred, was people being more concerned about the cost of dealing with cancer than the actual cancer diagnosis. People are concerned about these surprise bills, but if we can fix this particular problem, we will have had that one success. And then talk about it another day and place, sort of whether this goes on and gives us precedence for, one solution, whether you're for it or against it, that goes beyond this. It's kind of
I can foresee a scenario where something like the median or average in-network rate or percent of Medicare might actually work to bring some of these currently non-network providers into a more, into better contracting themselves. So it would encourage them perhaps to go into negotiations and contract with issuers and payers as opposed to reverting to the government.
Exactly. So answer on this is, this is absolutely not Medicare for all. And if somebody's raising that concern, do they work for the ER docs is what I would ask, because it just creates a really scary, it makes something that's very, very bipartisan. And like I said, in the House, we've got Texas former state legislators who are now in Congress who I worked on this when I was in Texas. This is a very bipartisan issue. Medicare for all is about the notion that the government really takes over healthcare. They set prices. You can't get healthcare unless it's through the government, right? This is not that. This is literally saying, we want to set a reasonable rate or show up and negotiate, right? To Al's point, show up and negotiate, establish an in-network rate, and the government's not even involved. Right? So really what it is trying to force competition in a market where, for example, the anesthesiologists are saying, we opt out and we're going to charge whatever we want. There's no competition. So this is definitely not Medicare for all. And I would be very suspicious, of folks who are coming to you with that kind of argument. And the other thing I was going to say too is, in my experience working up here, one of the most powerful influences is the member's own personal experience in healthcare. I can't tell you how many times I've been in negotiations and heard members bouncing back and forth about their own experience. Guys, this is all of us, right? We are spending 2 or 3 times more than the rest of the world on healthcare. There's no reason why an individual in this country who's paying for health insurance, right, paying their premiums every month, should have to worry about getting a $50,000 bill. That's what this is about. And your bosses know it, you know it, I know it, right? So please do not let them distract you and get into a space where it becomes so political. This is an utterly bipartisan issue, and it should be.
All right, thank you so much. I think Sarah's going to come up for a few quick closing remarks.
Just want to thank again Sarah, Jack, Frederick, and Al. Thank you to our panel. As you can see, this is a really complicated issue, and we could get probably talk for a few more hours, but we don't have time. You do have in your packets contact information for these wonderful folks as well as other experts. We encourage you to reach out if you want more information about this. Please fill out your blue evaluation forms and join me in thanking our panel.